themselves monitoring their blood glucose. Again, this is also a myth. It is not true. Older adults are also, at least majority of them are almost equally capable as any other adults. So pathogenesis of hyperglycemia in elderly. Again, diabetes itself is lead to hyperglycemia, and diabetes occurs for several reasons: genetics, coexisting illness, use of steroids, medications, and then the beta cell mass comes down with age, leading to insulin secretory defect, increased adipose tissue, decreased physical activity, and these things are there. Now, case of a mistaken identity. Signs of aging, we all know. This needless to say: glasses, urination frequency, change in gait, etc. But do we know that signs of diabetes can mix with signs of aging, like blood vision can be sign of diabetes. So an elderly patient who is a known case of diabetes, when complains you about the blood vision, don't think that it is only because of the aging. It may be because of diabetic retinopathy. Polyuria and nocturia. A more frequent urination will be there in all patients who are aging. That's not true. Polyuria and nocturia can be a manifestation of diabetes. Can't do things like you did when you were 20. Like that, people say it in a casual way. Fatigue, but fatigue can be a manifestation of diabetes. Atherosclerosis. Yes, atherosclerosis risk is there with age, but then that is also something which we can take care of. Neuropathy and foot deformities can be present because of diabetes, and they should be taken care of. Restlessness and confusion with high and low blood glucose levels are also part of the diabetes spectrum. So treatment recommendation, we should cover all of these points. We should be addressing the glycemic control part, the hypertension part, lipids part. We should take care of the eyes, the foot, the kidneys, and also we should urge for tobacco cessation in those who are taking tobacco. Stratifying older adults is also important based on their comorbidities, complication, risk versus benefit. Now, glycemic control, less than 7% is the target for HbA1c in those who are healthy adults. For elderly population, those elderly patients who are completely fit, there are many elderly patients who are actually completely fit and who have relatively longer life expectancy of more than 5 years. For them, the HbA1c target remains less than 7% only. If that can be achieved without causing reasonable risk of hypoglycemia. But then, if the patient is in extremes of age and for age or due to comorbidities, the expected life expectancy is less than 5 years, then we can keep the HbA1c target relaxed up to 8%, sometimes 8.5%, but not beyond that. Intensive glycemic control is not very much recommended for elderly because they can cause hypoglycemia, lead to polypharmacy, drug-drug interaction, drug-disease interactions. So who benefits from intensive glycemic control? Now, older adults who are having good health conditions, those who are not having any microvascular complications, frail elderly without microvascular complication will probably not live long enough to develop them. So therefore, those elderly who are having shorter life expectancy must be given relatively relaxed glycemic targets. Hyperglycemia in adult can lead to symptoms like delirium, mood swings, irritability, appetite changes, sleep disturbances, impaired cognitive ability, reduced energy, impairs memory, decreases wound healing, increases the risk of hyperglycemic hyperosmolar state, increases the urine output, increases the risk of UTI, and impairs the immune system. It also increases risk of diabetic ketoacidosis and hyperglycemic hyperosmolar state. So insulin may be a drug of choice to avoid this drug-drug interaction and organ dysfunction. Now, hypoglycemia in adults. Aging increases the risk of hypoglycemia because of reduced hormonal counter-regulation, renal and hepatic changes, hydration-related changes, inadequate or irregular medication, decreased intestinal absorption, autonomic neuropathy, again polypharmacy, and use of alcohol. Also, hypoglycemia can lead to heart arrhythmias, increased risk of fall, signs and symptoms which can be marked by comorbidities like Parkinson's, impairment of concentration and cognition, and impairs reaction time. So now these are the algorithm to simplify the insulin regimen for older adults. Now, basal insulin should be the choice insulin for elderly patient. You should start with relatively low dose, like for glargine, it is not more than 10 units as a starting dose. Then you should slowly up titrate twice weekly, not more than by 2 units per day. Also, usually glargine is given at night, but for elderly, it may be beneficial from hypoglycemia standpoint if you give it in the morning instead of night. And then if the patient is not being able to achieve good glycemic control on basal only and having high HbA1c despite use of 0.5 unit per kg body weight of basal insulin or getting fasting hypos, then you should introduce prandial shot of short-acting insulin analog. Now, insulin in elderly, as such, all the insulins are usually can be given. It's not that it cannot be given. However, there are some insulin in which the data is more compared to the other insulin. But anyway, I think this debate will not be a good one. All the insulins can actually be given. You will have to be carefully selective. In my practice, and also from the guidelines, what you've seen that for elderly to begin with insulin, basal insulin is actually very helpful, particularly glargine. Now, diabetes self-management training, more likely to include family members and other caregivers. Hypoglycemia prevention and treatment has to be taught. Benefits of medical nutrition therapy and physical activity, medication review, evaluation of foot care, amputation prevention, and evaluation of the geriatric conditions. Sorry. So practical tips for management in elderly: assess the functional independence and set appropriate and individualized glycemic goal. Insulin pen with analog should be the choice, particularly basal insulin to begin with. Addition of rapid-acting analog with adjust meal can be considered if basal only is unable to control glucose. Premix twice daily is convenient, but efficacy depends on regimented meal and lifestyle and not suitable in nursing home. Basal bolus therapy is ideal for busy individuals and offer advantage of tailoring the rapid-acting dose according to the meal intake. So with this, I stop here, but the session is open for discussion.
Thank you so much, sir, for such a crisp ideation of how to manage diabetes, especially in the elderly population. And as sir said, the floor is open for the questions. You can either unmute or you can post your questions in the Q&A section that you see. Meanwhile, sir, while we are receiving questions, I have a few questions of my own, and I thought I'll be asking you. So, as you mentioned that targeting of HbA1c becomes really important when we are having elderly and patients who have type 2 diabetes. So usually, as you rightly said, sir, that maybe target could be relaxed. So is there a way as to how you assess your patient that this is where I would put the target, be it 8, 8.5, or less than 8?
So there is no specific or objective way of this assessment. It is relatively subjective, but not completely subjective. It also has some basis. So you need to see the life expectancy of the patient. Now, again, when you are, when you are thinking about life expectancy of someone, life itself is not it's not in anyone's hand. So therefore, I said it is not 100% objective. But if you feel from your clinical assessment that this person is not going to live for more than 5 years for all reasonable reasons, then it is time to relax his A1C control, because we do not want hypoglycemia. And therefore, for those patients, we tend to target HbA1c of, again, it's not fixed at 8%. We will relax the HbA1c if the patient is taking multiple drugs. Suppose that same person is taking, having a life expectancy of 2 years, and he's perfectly well on a DPP-4 metformin combination, having an A1C of 6.8. So should we stop the medication? It's not like that. It's like that when the patient is taking multiple medications which can cause hypoglycemia, insulin, high dose of insulin, then probably we should relax it so that hypoglycemia should not happen. And we will relax it to a way, in a way that patient is not encountering hypoglycemias. By doing that, we can allow the A1C to go up to 7.5, 8. The upper limit is 8.5. Even if the patient is going to die after 1 month, then also you as a diabetes specialist, you cannot allow the A1C to go beyond 8.5%. That's ethically not allowed. The reason being, A1C more than 8.5% causes or start causing hyperglycemia related symptoms. So this will reduce the quality of life of the patient. It will start causing polyuria, polydipsia and all. So the quality of life of the patient will come down. So you can't do that. You cannot reduce the quality of life of the patient. That's the principal reason why patient is coming to you, for the better quality of life. So therefore, it is anywhere between 7.5 to 8.5%. Now that will depend on your patient to patient, situation to situation like that. Also, in some patients who are not so, not having such short life expectancy, but are having severe autonomic neuropathy and having frequent hypoglycemia, particularly asymptomatic. For them also, the target is loosened so that their reflex for hypoglycemia defense comes up, and it often comes. Hello?
Yes, sir. So, thank you for that answer. I think that is really how it should be done. One more thing, sir. Now, what we see is that there are newer drugs, maybe not so new anymore, but we have DPP-4 inhibitors, we have SGLT2 inhibitors, even GLP-1 is there. And as you mentioned that when we are talking about managing diabetes in elderly, basal insulin needs to be initiated. So how is the decision that either to go for these basal plus these newer medication, or the older like SUs, or go with the prandial insulin?
That's kind of a protocolized decision, actually. We go step by step. When you initiate insulin, usually for all adults, actually, but more so for elderly, we tend to initiate for basal insulin. Why basal insulin? This thing is coming more frequently in context of elderly. I'll tell you the reason. Because for normal adults, we do look for the delta between the fasting and postprandial plasma glucose also. But as you know, for elderly, the glucose targets are anyway loosened. So for them, the delta doesn't remain that relevant. For them, the regimen remains relevant, so that the glucose should come down to some extent, and the A1C should come below 8.5 at the first go. And many times on basal only, the patient achieves A1C of 8%, 8.1, like that. For patient who are in extremes of age, who have been initiated insulin just say 3 months back, and say for example they are taking Gladiators only, and on Gladiators say 20 units or so, their A1C is say 8%. Patient is 76, 77. So the patient is happy with one shot of insulin. There's no point immediately initiating on another shot. So it's like that. But having said that, for those who are young adults in whom we do tend to target A1C of 7 or less, for them also the basal insulin remains first choice, but for them we do see beyond that also sometimes.
So when would be a good choice to add, let's say, DPP4 or an SGLT2 in the elderly patient? Although
they can be added, DPP4 and SGLT2 both can be used in elderly patient, of course, after ruling out the contraindications.
Definitely, sir. And sir, with is there a choice of DPP4 or SGLT2 that would be preferred when we are talking about elderly patient?
No, not much. I think the choice will depend on the overall clinical profile of the patient. Yes, choice is there. Choice based on the liver function test, choice based on the kidney function test, choice between DPP4 inhibitors are there. Choice is less available for SGLT2 inhibitors as such, because for them the usual initiating criteria and the contraindications remains almost same. So for SGLT2 inhibitor is more so what you are picking up. But for DPP4 inhibitor, there are some choices, of course.
Definitely, sir. Thank you for that answer, sir. And sir, although the topic was extreme of ages, and we have at this one, we have only discussed elderly. So does the management usually changes when we are dealing with another extreme of the age, that is a pediatric population?
Yes, certainly. Management will change. So for pediatric population, if you talk about extremes of age, so that means you are actually talking about kids in their first decade of life. So kids in the first decade of life are almost always type 1 diabetes. But those who are diagnosed with diabetes in less than 1 year of age, they are more likely to having neonatal diabetes. Actually, neonatal diabetes is a separate entity. It is different from type 1 diabetes. For neonatal diabetes, we tend to choose basal insulin at a very low dose, of course, needless to say. But sometimes oral drugs are also given. I think that's a topic which is beyond the scope of discussion in these webinars and all. So probably I will not like to speak on it so that no accident takes place. But for type 1 diabetes, there are some basic rules which you need to keep in mind. You must always give some basal insulin to the patient. You cannot give premix insulin. You cannot give. So among the basal insulin, the modern basal insulins are preferred. All 3 basal insulins are approved. I think you can use U100 glargine, U300 glargine is also nowadays used, and of course, degludec is also now approved. So among them, then there are studies which suggest that probably the newer basal insulins are causing less hypoglycemia, but in clinical practice, we don't notice such things more often. So we think they are more or less same. The patient should be comfortable cost-wise. ऐसा नहीं होना चाहिए कि patient was given some insulin and then that patient discontinued it. It should be your priority. So for all these reasons, glargine is something which is still used most often for type 1 diabetes. Usually the starting dose is around 0.1 unit per kg body weight, and that's the dose in which the decay is also prevented. And so that dose has to be taken by the patient. Impoverization of patient is much more relevant for type 1 kids than type 2. We talk about impoverizing type 2 diabetic patient. That can be done, but doing or not doing is up to you for type 2. But type 1 diabetes, if you do not empower the patient for insulin titration, then that's something which is very wrong. Kids are very smart. If you teach them, if you give them proper time, 6, 7 years onwards, they can manage their insulin. It's like that. Relatively, if the kid is not very much oriented, then also 8, 9 years is good. Yes, titration part should not be left to the kid. It should be done in consultation with the parents. Parents should be, adequately trained by you. But again, regarding this basal insulin administration, there will be type 1 kids who will be coming to you maybe at the age of 10, 12 with their parents, and parents will say that they give the insulin because the kid is afraid about it. In our OPD, in our system, we don't allow this. We just ask the patient, the kid and the parents, that they have to learn to give insulin on their own, because it's not for type 1. We cannot depend, the kid cannot depend on anyone except himself or herself for insulin administration, because same timing and all has to be maintained. So these are things which you need to take care
of. Yes, sir, definitely. In fact, the kids are so smart, especially type 1, that they actually learn that if they are snacking, what amount of bolus they have to take over a period.
They learn carb counting, they learn everything. You teach them, and the carb counting is there in apps now.
Yes, sir. So now that
carb counting, they have to be little grown up, because they need to remember the carbohydrate content of various foods and also a little more aged kids can do it.
So going to the other extreme of age, how important is this the care provider education in terms of elderly, especially if
it is important to educate the care provider in elderly also. So that's also very relevant. That's also relevant, particularly hypoglycemia and all. You need to inform the care provider. For patients who are defenseless, who cannot defend themselves, like dementia patients, post-stroke patient, for them you need to inform them that glucagon has to be kept at home. Glucagon shot has to be given, because sometimes the patients are bedridden. You cannot give them dextrose. They will aspirate and then they will end up in ICU.
Thank you so much, sir. And it was really wonderful having you as a speaker. And now I'd like to invite our Mr. Vishwa, who is heading the marketing for the vote of thanks and meeting closer. So over to you, Mr. Vishwa.
Thank you, Dr. Kunal. And before I proceed for vote of thanks, I just like to share a very good news with all of you. So here it's on the screen that Wosolin is turning 20 years old. In 2003, we launched Wosolin and put India on the global map of insulin manufacturers. And after US and Europe, India became the third country who started producing own insulin in the form of Wosolin. So thank you very much, all the doctors of medical fraternity. Thank you very much for your guidance and support you have extended towards Wosolin. And Wosolin is going to turn 20 years. And still Wosolin is offering most affordable insulin, starting with 78 paisa per IU. So thank you very much for all of you to support Wosolin. And now I would like to begin by expressing my deepest appreciation to Dr. Amitabh Sur sir for his insightful and thought-provoking presentation, and my heartfelt appreciation to all the delegates who have attended this webinar and added immense value in this event. And my sincere thanks to Dr. Kunal for his exceptional moderation skill throughout the webinar. And lastly, I would also like to express my gratitude to the Diabetes Division field team and all my HOKL colleagues who have worked tirelessly behind the scenes to ensure the smooth execution of this webinar. Concluding here, thank you all once again, and we look forward for your continuous support. Thank you once again. Signing off. Thank you very much.
Thank you. Thank you, sir. Thank you, everyone. Have a great day ahead.